Welcome to the Cannabis Pharmacology Learning Module Section 4, Adverse Effects, Interactions, and Contraindications. Common adverse effects associated with cannabis use include drowsiness, dizziness, dry mouth, coughing and phlegm with smokable dosage forms, anxiety, cognitive effects such as euphoria, short-term memory loss, and distorted sense of time, and transient tachycardia. More rare adverse effects associated with cannabis use are orthostatic hypotension, psychosis, paranoia, depression, ataxia, persistent tachycardia, diarrhea, and cannabis hyperemesis syndrome. The majority of cannabis side effects are associated with THC and are usually easily mitigated with slow titration of dosing to promote tolerance to these side effects. Cannabis-naive and elderly users are more likely to experience adverse effects with THC and should be given dosing instructions with this in mind. Cannabis hyperemesis syndrome is a rare adverse effect of cannabis use and typically occurs after prolonged use of high concentrations of THC. Cannabis hyperemesis syndrome is characterized by intractable cyclic vomiting, which can be immediately alleviated by a hot shower. The mechanism of cannabis hyperemesis syndrome is unknown, and research is currently being done into possible genetic predisposition to the development of this syndrome. Subsequent cannabis use in cannabis hyperemesis patients will result in recurrence of symptoms, even after prolonged abstinence from cannabis. Therefore, discontinuation of cannabis is the only assured cure once cannabis hyperemesis syndrome develops. As previously mentioned, tolerance to the side effects of cannabis occurs rapidly over several days, with no loss in therapeutic benefit of cannabis medication. The mechanism of tolerance isn't completely understood, but is thought to be due to receptor downregulation and desensitization. Initiation of cannabis therapy and subsequent increases in cannabis dose should occur when the patient is in a safe, stationary space to avoid unnecessary risk if adverse events occur. It is also advisable to tell patients to begin their cannabis medication in the evening, so if adverse effects do occur with the first dose or two, they will go to bed and be able to sleep through them and try a lower dose on the subsequent day. Patients should be counseled to titrate their cannabis slowly in order to mitigate the experience of adverse effects. It is also important to let patients know that the majority of adverse effects of cannabis are transient and will resolve with time as tolerance develops to the medication. If patients experience coughing with inhalation, advise patients to reduce the temperature settings of their device if they are able to. Taking smaller inhalations or a sip of cool water to reduce throat irritation can also reduce the incidence of coughing. If patients experience an increased heart rate, they should know this is typically transient and should resolve within 15 to 20 minutes. If it does not resolve after an hour or more or is accompanied by chest pain, patients should be advised to contact an emergency healthcare professional. For patients experiencing dry mouth, fluids, gum, or lozenges can all be used to increase saliva production. Red eyes can be alleviated with over-the-counter lubricant drops. If patients experience euphoria or paranoia, it is important to remind them to remain calm, as this poses no actual harmful threat to their body. Instruct the patient to hydrate and eat a light snack. Sometimes, moderate activity such as taking a walk or participating in meditation, listening to music, or watching television can help reduce the amount of euphoria or intoxication the patient is experiencing. A nap can also be helpful, as well as taking a relaxing bath or shower. There are several contraindications and precautions to consider when determining when cannabis therapy is appropriate for your patients. Any patient with a personal or significant family history of schizophrenia or psychosis should not use any product containing high amounts of THC, as there has been a large amount of correlation between high THC use and the incidence of schizophrenia and psychosis. Note that this is not a causative effect, simply a correlation. But until the actual relationship between THC and schizophrenia or psychosis is better understood, it is best to avoid THC formulations in these patients. However, multiple clinical studies have shown a benefit in using high CBD in these patient populations, so cannabis can still be an appropriate therapy for them if used at the appropriate ratio of cannabinoids. Due to the tachycardia seen with cannabis use, patients with active, unstable ischemic heart disease should not be using high THC cannabis therapy. Additionally, anyone with a hypersensitivity to cannabis or the components found within cannabis formulations should not use cannabis medicines. Relative contraindications include pregnancy and breastfeeding. As with most medications, there should be a risk versus benefit assessment of whether cannabis therapy is appropriate for a pregnant or breastfeeding mother. Advanced age can be a risk factor for using high THC medications, as they can put a patient at risk for a fall. Severe liver or renal disease should be assessed prior to the initiation of cannabis therapy, although most issues with liver or renal disease and cannabis can be resolved with cautious titration of medication. Concurrent use of psychoactive or sedating medications should also be considered when initiating cannabis therapy. Patients with a history of substance use, particularly with a compulsive use behavioral disorder, may be at risk for the development of cannabis use disorder and should be cautiously evaluated prior to the initiation of cannabis therapy, particularly when containing high amounts of THC. Pre-adolescent age, similarly to pregnancy and breastfeeding, should be assessed on a risk versus benefit factor, and THC should be dosed very cautiously in these patient populations and minimized whenever possible. Patients with COPD or asthma should avoid inhalation dosage forms of cannabis whenever possible. When evaluating cannabis for drug-drug interactions, both pharmacokinetic and pharmacodynamic effects must be considered. Pharmacokinetic effects include cannabis acting as a victim, whereas cannabinoid levels are changed by the presence of another medication, or cannabinoids acting as a perpetrator, where the cannabinoid causes the change in levels of another medication. Pharmacodynamic interactions are when both drugs contribute to overlapping side effects and the concepts of victim and perpetrator do not apply. It is important to understand that the route of administration of cannabis plays a significant role in the potential for drug-drug interactions, as only oral administration involves first-pass metabolism, whereas inhalation or mucosal administration does not. Few studies have been conducted on clinical drug-drug interaction with cannabinoid therapy. Several existing conclusions regarding drug-drug interactions have been drawn from in vitro drug metabolism studies. The majority of drug-drug interaction information we have comes from studies where drug-drug interaction assessment was not the primary study objective. THC and CBD are substrates of the cytochrome P450, 2C9, 2C19, and 3A4 families of enzymes. Inhibitors of these enzymes, such as clarithromycin, fluconazole, fluvoxamine, gemfibrozil, grapefruit juice, and protease inhibitors, will increase cannabinoid levels in the body, whereas inducers of these enzymes, carbamazepine, St. John's wort, phenytoin, and barbiturates, will decrease the levels of cannabinoids in the body. These interactions are typically easily managed with slow titration of cannabinoid dose. However, initiation of a new medication for patients currently using cannabis should be assessed, as a reduction or increase of cannabis dose may be needed. THC and CBD both inhibit cytochrome P450 2D6, and CBD inhibits the 2CA, 2C9, and 3A4 family of enzymes particularly potently. There is a potential for increased concentrations of associated substrates of these enzymes, including calcium channel blockers, benzodiazepines, statins, SSRIs, tricyclic antidepressants, warfarin, and clobazepam, among others. For the majority of substances observed in studies, the increases in concentration remained within the therapeutic range. Also, these interactions are typically observed clinically at very high doses of cannabinoids, for example, CBD at 2,000 milligrams per day. Slow cannabis dose titration and patient monitoring is key until we have a better understanding of the actual incidence of these drug-drug interactions. Additionally, similar to cigarette smoking, the smoking of cannabis results in the induction of cytochrome 1A2, which may decrease available levels of theophylline, antipsychotics, and caffeine, and should be considered for patients who are smoking cannabis and taking medications which are substrates of this enzyme. When it comes to the pharmacodynamic effect of cannabinoid drug-drug interactions, an additive psychoactive effect has been seen when cannabinoids are administered with alcohol, benzodiazepines, opioids, anticholinergics, muscle relaxants, or other central nervous system affected medications. Often, patients are looking to reduce or discontinue the medications that contribute to this additive effect, but caution should be used in patients on multiple medications with central nervous system effects. When it comes to opioids, cannabinoids increase the therapeutic index of opioids, meaning that combined therapy with cannabis and opioids results in a greater than additive anti-pain effect. It is important to understand that cannabis does not increase the level of opioids in the body, and therefore, co-administration of cannabis and opioids does not result in an increased risk of overdose for the patient. The use of cannabis and opioids will be covered in more detail in the Opioid Use Disorder Clinical Indication module.